This next week is a little messed up because we'll miss out on lab because of Volunteer Appreciation Day. However, as you saw, if you want to do an adjustment on that day after you do your volunteers in the morning, I think it was 1:15, afternoon reserve 2:01. So come up and follow us off the adjustment or work on something if you like. So that's up to you. It's opportunity. I'll be there. Okay, be kind of a relaxed atmosphere. Okay, what the presentation is in your Moodle page for TMD is overlaps very, very, very significantly what we're going to do in lab. So I'm not going to do that separate. One thing I want you to I want you to think of though as a primary adjustment of the jaw from HVLA is usually what we sometimes call a centration adjustment. From the standpoint of when a person loses long axis, kind of open up the space and let it come back in and find its home. Okay, so that's what centration is. It allows it to become in the center of the joint, hopefully. Okay, so a long axis of the jaw, a couple things that can make that easier. One, use that universal skull hold or occiput hold. So my fingers like this behind their head. Okay. Turn their head so the fixed side of the jaw is up. And you can put the pisiform right here, right below the zygomatic arch. Then you have to have a certain amount of compression between your two hands in order so you don't slide so much. The other thing that can help you slip from slipping if you have a slippery person. Some people are oily, or if they have facial hair, that can be slippery. Using a glove, especially those nitrile gloves, are good for helping you get a grip. If they don't have facial hair and they're a little slippery, another thing that works well is just a little bit of ultrasound gel. If you put a lot on, it's slippery. If you put just a little bit on, though, it's kind of sticky. And then you can kind of not have to squish their head so much to keep you from slipping. Okay, so that's the main thing. And so that would be useful. If they have some kind of restriction in their gait of their jaw, we have those other ways of trying to deal with like a clinking disc and so forth. But if they have a jaw problem, and then when you did the distraction test, you kind of noticed, well, it seems like they don't have the distraction on the right side. Maybe it's in the context as a synovitis as well, maybe not. You can always do test bus impulse, right? So you could hold them like that. It'd be better if you have an assistant kind of hold their forehead and you could test, and then you could still do impulse, and that would be a long axis as well. It's just more difficult to get as dynamic with that. So if I really want a separation adjustment, I'll do this one. Okay, so that's pretty much the jaw. There's 8 problems with the jaw, or 6 main problems with the jaw from an articular standpoint. We went through there, and then there's 4 big muscles of the jaw. If you kind of think of those 12 things, when a person has articular problems in the jaw, you're way ahead of the game. Okay? Because the patients will have various kind of combinations of those things. Okay? And it gives you, I think, a pretty good framework to attack the jaw. The next time a person says they have TMD, you can kind of subdivide it and kind of say, well, what version do they really have? All right. Any questions or corrections on the job? I want to tell you that you have screwed up my life. Not you just by singular. But I was thinking, maybe it'll be just nicer to just, maybe I'll just do about the 6 one more time. And then you guys came on. It's like, you guys are fun. You guys work hard. This is too good. So, keep it going. Just so you know. All right. So, one of the things that you've been done a bunch of times is reflex sensory motor. So much so that you don't even pay attention anymore, or maybe you never did at the beginning. And in some ways, a lot of times you don't have to, because very rarely do you have hard neurologic findings in persons that come in with the common complaints that patients come to chiropractors for, including neck pain and back pain. It's been estimated by Souza that 3% maybe have hard neurologic findings. So don't expect these things to be abnormal very much. Then if you kind of realize the real kind of normal range, like reflexes is 1 to 3 plus range normally, then all of a sudden, yeah, you got a lot of more people being normal. But if you start doing muscle testing a little differently, you might end up having more people normal. So I jumped past TMJ now, or TMD, and now I'm into radiculopathy for the next week. So that's where this stuff is getting come from. This is one of the videos that's in the next week section in Moodle. So you can do neurologic, like a gross neurologic screening test. Okay, if I do that, can you hold up your arm like this? Okay, don't let me push down. Okay. What was the grade of that muscle?
5.
Well, it wasn't grossly weak, so it's 5 plus. A lot of people call it. But do I really know what 5 plus is for her? Only if I'm able. Gone through this with Zach. Okay, so how do you know? How do you really know what 5 plus is? You only know what their full muscle strength is if you test it to its limit and you put a pressure on there more than the top of their limit. Because if you put anything less than top of their limit in there, you don't really know what their upper limit is. Got it? Okay, so I can tell you, she doesn't have gross neurologic deficit. She's got good normal strength. Do I know what her 5 of 5 is, really? Can I compare it to this is the important part. Can I compare it with the other side to see if it's minorly weak? Because when people have radiculopathy, they don't have 4 or 3, they have 4 plus. Okay, so it's kind of between 4 and 5. So if you don't really know what their true 5 is, you don't really know if it's between 4 and 5. And then you don't know that if it's getting any better, because you don't know what it was to begin with. So let me kind of try to demonstrate that in a different way. You're the strongest person in here, right? All right, so if I'm doing a muscle test on him, first of all, if I want to be stronger than him and make it so that I find out where his deltoid crumbles, how am I going to do that? Well, I get a long lever for our northern friends. Long lever, and then if I get my body weight on top of it. Okay, hold up your arm. I'm going to push down this way. Don't let me. Come on, try this time. Okay. So the other thing is, after they figure out, they're stronger the second time. So you kind of 1 for training, 2 for fine. Okay, so now hold it up. Don't let me. Okay, so now I know exactly what 5 is for him. If I go like this, don't hold up. Okay, hold up on the other side, or hold up, both of them. 5. Okay, what you want to do to get through the exam, right? But if you've got radicular complaint, I think he might have a C5 radicular complaint. I want to see if his left side is a little weak. So I find exactly what his right side is like. I'm going to push down. Don't let me. Come on, don't let me. Okay, now I know exactly how strong that one is. All right? And so now I can do this side. Can I go push down? Don't let me. Oh. It's like 90% of the other side. The other thing to throw in there, your dominant side is going to be a little bit stronger normally, right? Okay, so when you do it this way, you'll find that out. That if their dominant side is stronger, or sometimes you'll find out, hey, their other side is stronger in this particular muscle. Okay, so that's the concept. Is that there's 5 of 5, 1 through 5, trying to grade muscle strength for people who have strokes and so forth. But then, if you as a chiropractor seeing somebody with radiculopathy, you want to know if it's a little weak, because you want to know if your therapy is helping them. So you want to have one objective sign to be able to tell that, and muscle strength is one of those. Then you get in a position to just beat the muscle. So what do? Use long levers and body weight. Okay, so when it comes to triceps and biceps, you'll see there's a couple other ways. So let's just look at this person do the upper extremity. It doesn't speak very loud. Check circle number 5. So you have this out like this, and you'll hold it up, and then you push it down and go. So you get it over the top. And one more time, let's check that. And the other side, let's compare. Those should be similar. Okay, one more time. Within 10%, usually the dominant side, maybe 10% stronger. Okay, so that's the deltoid. C5. C6 commonly do the biceps. Biceps, and just have your arms out like this. And I'm going to go through 2 joints, so I'm not going to press up here. We have press on is to say venial or misdemeanor. What's worse than misdemeanor? Felony. Misdemeanor is if you go through 2 joints. Felony is if you don't do the test. So if I use my body weight, I'm more likely going to be able to really tell when his muscle breaks. So I'm going to push down. You don't let me. Over the top. Here at a big mechanical advantage. I can do that in a strong personal thing. Okay. So 5 out of 5 is the muscle. So what interval was that for?
6.
6. Well, when you do the reflex, what muscle or what nerve level for?
C5.
Well, it wasn't delta, it was C5 for muscle strength. Okay, so obviously bicep must be C5, C6. All right. Good thing. For that muscle. Okay, also for C6, you can check wrist extensors. In that case, you're going to put your hand right in your lap, and I'm going to push down from the top here. Let me. And then for cervical 7, then we can check a couple other structures. One would be the triceps. I'm going to put your arm up like this. I'm going to push it towards this way. That's number 7. That would be 5 to 5. Number 7, same idea. 5 out of 5. Okay, so also for cervical 7, you can check wrist flexors. So have your tap down in your lap again, and push down from above, down from above, up at me, a little stronger. And right side, I'd say it's still close enough. That'd be 5 of 5. That's the strength there. Last one for wrist extensors, or for cervical 7, is finger extensors. So the way that you can check those, so I'm just going to put your hand in your lap and just keep your fingers pushed out straight. I'm going to push down. Don't let me push this over the top. Don't let me. Same idea, I'm going to put it over here. Okay, got the microphalangeal joints. Let me. So that's cervical 7. And then for cervical 8, it's commonly finger flexors I use. To check for cervical 8, I'm just going to have you make a hand kind of like this. And I'm going to try to straighten out the fingers. Don't let me. 4. Okay. I can try to straighten your fingers about that. Alternatively, sometimes people will check the cranial nerve 8 by having the person grab my fingers and see what's right in the palm and put in a whole wrist and out squeezing really hard. Engage if they're the same alone. Okay. For 5 to 5. That's more trivial, but that's more examination of upper extremity. All right, so a couple things. Which of those is probably the most important to be able to do well in one? Well, which nerves get involved the most?
5, 6.
C6, C7. So something, then C5, and after that C8. Okay, I've never seen a C. Okay, so it's hard to sometimes, if people have really strong finger flexors, it's going to be hard to defeat them even using any leverage that you can. If you do use the squeeze test to kind of do the gross testing of number 8, then put your fingers in like this. If you twist them, then your knuckles don't get squished together. Okay, that doesn't hurt you as much. Okay. If you're into pain, then just whatever you want. Okay, so then that's just kind of the preamble because I am kind of interested in people being able to do a good knowledge exam, correct? And I'm most interested in doing a peripheral exam. You better go to a peripheral exam because that's really what we're working in the vast majority of the time. So small differences can give you some good hints with your patients. So there's some things in radiculopathy that are misnomers, and so we're going to go through some of those. There's going to be a couple repeats in here just because there's some things that are important. But you're gonna find out that the standard tests that you've been shown for the extremity muscle testing, and that you're just shown again, is not the most sensitive test for finding a C6 problem. So we'll find out what it is. Just paying attention to stuff. All right. So classic presentation. Okay, what is this?
Cody.
Cody sign. What does that mean? They're more comfortable with their hand up here. Why are they more comfortable with their hand up here?
It's not stretching the nerve root.
Things are slack as the nerve root. Okay. If the nerve root, if it's detention. So depending on the person's presentation, I remember one of the first disc persons I had that was verified by MRI. This actually made it worse. Well, what happens if your hand in it? Oh, that's much worse. So none of these things is good 100% of the time. Okay, they may have occur after an injury, but not all the time. And the major cause, as you're going to see, is disc herniation. Okay, they may have multiple disc or multiple bouts of pain, just like in low back, before they have a big blow up. They may have weakness in their hand or arm. The pain is a deep ache and constant, typically. It's very wearing on them. And they may get relief with the Cody sign in the classic presentation. Okay, so only 20 to 25% of the cases is due to disc herniation. Okay, and so here's what happens in the disc herniation. And there's certain levels that are more likely that the herniation is going to cause radiculopathy. And those are the levels where the disc and the nerve are at the same level. But if you get old like Dr. Zachman, then you have less chance of getting disc herniation, especially in the cervical spine, because your nucleus pulposus is making a trick. Let's get this fancy team together. Okay, so the nucleus pulposus becomes fibrous, and it's less jelly-like, and so it's harder to push it out. Okay, so not all things occur more often when you're older. Okay, testicular cancer after 30, 35, it goes away. All right, so certain things happen in younger people, like disc herniation. Okay, so and part of that is because there's a change. People get shorter as they age too, right? So 1/3 of your spinal height is your discs. Okay, so then as they start to compress, you lose some spinal height, so you lose some of your total height. So oftentimes you ask a patient, how tall are you? They'll say, well, I used to be 5'7", because they know that they're short. Okay, so if I get taller again, go up in space for a while, come back. Astronauts, when they come back, are almost 4 inches taller for a while. Okay, how did I get that? Sorry. Approximately, the biggest cause, it doesn't herniate as long as often after 50 to 54 years of age, so that's the definition of old for today. Okay, histotrauma is found in 15% of cases, which means 85% is not. Okay, the total incidence is somewhere about 3 per 100,000, and 70 to 75% the other big chunk, the biggest chunk, are actually due to foraminal encroachment degeneration, not degeneration. So that's a big misunderstanding in the general public and a lot of healthcare places actually. And so there's different reasons why that occurs, but your IVF just gets smaller with you when you get decreased disc height. Your IVF gets smaller when you get degeneration of osteophyte formation or syndesmophyte formation in the cervical spine. You can get it from both sides. You can get it from the set side, or you can get it from the vertebral joint side. However, a lot of times patients will come in and then they say, yeah, so I have a radiculopathy or whatever, so I have this problem with a nerve pinch at C5. Okay. The reason is because I have arthritis. 2 weeks ago, their arm was fine. So that 2 weeks, they suddenly got a lot more arthritis, or did something else happen in that 2 weeks? And maybe they can get back to where they were 2 weeks ago, and they don't have to write themselves out. Okay, so evaluation, certain things that are really big deals, and the literature kind of supports in the most kind of recent way. And so here's the big deal. Number one is you think they may have disc herniation if they have less than 60 degrees range of motion. Okay, so especially in a young person, you know, somebody's 25, something like that, you're going to think that they have something pretty wrong if they can't turn their head 60 degrees. You know, if somebody's 85, you know, they might not turn 60 degrees either way and haven't been able to for a while. So you have put that into your algorithm. Okay, orthopedic testing, Sperling's test may reproduce the neck and arm pain. And there's different Sperling's tests, right? Sperling's A and Sperling's B. Did you guys learn that? Well, Sperling's is kind of a compression test of sorts. The one where you go straight to the side, that's a Sperling's test that has the kind of the best usefulness. Okay, the other one, which is maximal cervical compression, it's got there's some other names in there, where you extend, rotate it, and lateral flex, you know, they would tend to increase the IVF as well. The one that's the simplest to do, probably the most useful from an evaluation standpoint, is straight to the side. So if you're doing that, you're kind of doing cervical compression, or you're doing Sperling's A test on this side, at the same time you can push their arm down, and then you can do a shoulder depression test, and so you get two things done at once. And so then the important part, though, that sometimes gets left out, when you do that, where does that hurt? Yeah, okay. Where's it? It's always more, better information. Is that reproduce the symptoms you've been complaining of? Yes. Okay. Well, then now that's a positive test. No, you'll get weird things. Does that hurt? Yeah, where? Down here. Okay, somewhere in a whole different region. So if you don't ask, you won't know. Okay, so that's a cervical compression test, Sperling's test. Cervical distraction test will be, kind of gets confusing. What makes a positive test? Well, for a distraction test, positive test is if it relieves the symptoms. Okay, so but then it gets confusing. So just say distraction relieves, then you don't have to worry about positive. But it should relieve their symptoms. It's not like, oh, that feels good, because pretty much everybody feels good if they have their neck stretched a little bit. The other thing is, you can't tell if it relieves their radiculopathy unless they have radiculopathy. Yeah, so if you're doing a distraction test, you know, in reality, you know, what's the point of really doing it if they don't have any arm pain? That's the purpose of it. Okay. They're relatively insensitive but moderately specific, these two tests. We already talked about Cody's. Okay, so shoulder depression test. So if you're doing shoulder depression test, you're kind of doing a Sperling's test on the short side. Okay, in the classic case, the patient will have a corresponding deep reflex change, myotone or muscle test change, and a sensory change. If you could only do one of those to evaluate radiculopathy, which one would you use? You said sensory. Why?
Can differentiate spinal from peripheral.
Well, sensory is nice because there's one for every nerve. I feel like a reflex is why we don't have one for every nerve, so that kind of makes it a little harder. But muscles, we pretty much have one to kind of indicate each of the cervical nerve roots. I will tell you that from an examination standpoint, sensory tends to be kind of more all over the place. And it's less predictable and changes less when you treat a person. So for me, the one that if I could only do one, I'd do the muscle test. Because that one you can kind of grade it a little bit more than the reflexes. Reflexes are good for telling if there's gross loss or gross change, but muscle test you can kind of keep an eye on a little closer. Different people have different ideas on that. That's just my own personal. Okay, radiographs for radiculopathy. If it's an elderly person and it's one of that 75% you think is due to encroachment, osseous encroachment, well then maybe some usefulness for X-rays in that case. But X-rays are not therapeutic. So sometimes you have to make clinical decisions which radiologists don't make. The radiologist, oh, take more x-rays, get obliques. Your patient's kind of going, more obliques? This is kind of tapping me out already being here. So there's the reality of finances that you come to play. So sometimes you have to decide, is more imaging, do I really have a handle on this? Is it a better use of their resources to do a trial therapy or get additional imaging? So that's where clinical judgment comes in. Okay, CT scans and MRIs, control things. I've yet to see a normal MRI. Okay, so patients, so MRIs will come back with herniation at a different place than where they have physical findings. They're going because they have an ankle problem, they get MRI, and they have inflammation between the metatarsal heads and other stuff. So they have MRI will find some things that aren't clinically relevant at the time. Okay, so it's not a perfect test and it's expensive. Okay, so but sometimes it's necessary. But it is shades of gray. Electrodiagnostic testing, I rarely send a person for this for a couple of reasons. One, it's really uncomfortable on the receiving side. And two, it doesn't really become positive on the performer. So, okay, so on the front end of things, even if you have somebody with reflex changes and stuff, like, oh, we should get some electrodiagnostic testing. Some of the stuff for electrodiagnostic testing really doesn't become positive until later, so it's probably better to kind of wait for that. Again, it's not therapeutic. It can be therapeutic if it helps you identify to treat something that you wouldn't be treating otherwise. The definition of a good diagnostic test is that it finds something that's generally fairly common in the population. There's something that can be done about it. So if you're going to search for something to get a diagnosis where there's no treatment for it anyways, then it's kind of like, well, is that a good diagnostic test? Hey, management, this is my brother. Watch corner. This guy. Okay, the natural history is favorable for disc and radiculopathy problems. 90% will fully recover with surgery. Sometimes it takes a while though. Home didn't burn down in a day. It takes a while to get these things taken care of. Okay, so cervical manipulation. So you're gonna adjust somebody who has radiculopathy? I am. Am I gonna adjust, oh, it's a C6 radiculopathy, oh, adjust C6. It's the rule for me is the same. I'm gonna adjust the most subluxated segment. C6 might be the victim. It's trying to move extra different because some other fixation in some other location. It might be at that location. It needs some adjustment in order for some of the swelling for the facet to go down, for them to have a good circulation in there so that and pumping action so the congestion can go away. So it might be at the level. However, it's recommended by most learned people in manipulation that you kind of do a little test on that idea. So that if you're going to do a manipulation at C5 in this direction, you kind of do a test, like a mini test run, and say, how's that going? Does that feel like it's going to be all right? Okay, and they can kind of tell you. If it's really blowing them up before you even get there, you can kind of imagine that it's probably going to be not very well received as they're doing it, and it might stir the pot more than help. Okay, so in the wherever you think that the resolution of the joint dysfunction is going to be helpful, set it up and try it out. Okay, this is where a seated capability can be very useful, because if you've ever seen a person with acute radiculopathy, you tell them to lay down on their back. As they lay down, they start going like this, and you ask them how they're sleeping. They're sleeping terrible. I sleep in a chair, sitting up, because when I lay back like that, my arm is a lot worse. Okay, so wow, that makes your arm a lot worse. Okay, well, lay down like that, and we'll adjust it like that. So that doesn't make a lot of sense. In this case, having the person in a seated position, maybe a slight flexion, that way might have some usefulness. Occasionally, you might get a person to be able to relax better supine in this situation. So you kind of have to check it out, try it out sometimes. The idea is though, you can hopefully do it regardless. You got a choice. Okay, so that they have neurologic findings to begin with, and so they already have a disc herniation or osseous compromise. So just keep in mind that as you start having extra motion, sometimes patient symptoms may be enhanced a little bit. It's good to document that they had the neurologic findings before you worked with them. And so then if anybody would had questioned the idea that those chiropractors that did it, that you did it, say, well, I had a guy across the street, his dad used to tell me, go over there and say, well, I don't believe in chiropractors. So I said, well, pinch me, or pinch yourself. I said, we exist. You might not like what we do or agree with what we do, but you gotta believe in us. We're not kind of some mystical thing or something. So, and so why is it that you don't believe in chiropractors? Well, I had a friend who went to chiropractor and ended up having surgery on his low back. I had a friend who went to orthopedic surgeon, ended up having surgery on his low back. Okay, sometimes people have a problem that's beyond conservative measures. Maybe the chiropractor found that out, and your friend ended up having to have surgery. Sometimes there's this automatic, he went to the chiropractor because he went to the chiropractor. He had this problem. Person's having a stroke, you go to the chiropractor. Went to the chiropractor, you had a stroke. People that have problems go to seek help here. Sometimes, if you determine somebody's not on your island, try to send them to an island where it can help. Here's something that's commonly done wrong: cervical traction. Cervical traction is, it's good to have at-home things that patients can do to try to help themselves, especially if they are having pain issues. Managing pain is something that's in the press a lot right now, and ice helps, anti-inflammatory strategies help. Sometimes physical traction can help. So this is seated cervical traction, and so this is probably should have made this arrow like red or something. This is the wrong one. Okay. Generally, for people with their radiculopathy, they're going to get increased size of the IVF with slight flexion and traction. Okay, so the rope should always be going forward like it is this lat here. You can see this is a nice way to do it. There's water in here, so depending on how much water in here, you can change how much the weight of the traction. Okay, so generally, a lot of people say to start out with the lower mouth, but your head's 10-pound-ish or so. So a lot of times that's where you start. And that's really not traction; it's just removing the weight of your head. The other thing is patients have to do this a few times to figure out how to relax it, because for every action there's a reaction kind of thing. So sometimes the first thing is there's a force pulling this way, they kind of pull against it. So you kind of have to figure out how to just let it go. And so occasionally this can be useful. One of the common protocols is 15 minutes twice a day. Okay, it's nice because they can do it at home. They just do it over a door. They have this pulley system here, and then it's relatively cheap, $22 or something. Medical related device, this is pretty inexpensive, and they have medical. Okay, so let's just look at some things. Does a person truly have radiculopathy or not? What is really the presentation that the person has? Okay, first of all, not everybody who has radiating symptoms has radiculopathy. In fact, the minority. I see way more commonly myofascial referrals to the hand than I do for radiculopathy. The person comes in and they have tingling in this ulnar side of my hand. Of course, I'm thinking C6, C7, C8. I told you it was the last time I saw a C8 radiculopathy.
Never.
Right, so I'm already thinking, well, it could be, but maybe something else. What part of the hand tends to get involved most common in thoracic outlet syndrome? Ulnar side. So what muscles contribute to thoracic outlet syndrome? Pec minor and scalene, and then the interclavicular space above the first rib. So I'm going to be looking for pec problems, upper CT or upper thoracic CT junction problems, and I'm going to be looking for clavicular. They had a clavicular fracture, and then heal, and there's a bump on it, there's less room. They have long transverse processes, C7, they might be, or cervical ribs, they may be more prone. Okay, so looking for anything that would explain that. Okay, then when it comes to related to that, then there's the thoracic outlet test. Okay, and the thing that really makes them positive for me and for most practitioners is reproduction of their symptoms. You'll get plenty of false positives as you start doing the pulse. Okay, when do you have the symptoms all the time? Well, does this make it worse? Yeah. What happens on this side? Well, I get it on that side too. Okay, so you gotta kind of make sure that it reproduces the familiar complaint, is what Susan terms it as. Okay, so it doesn't matter if you're doing like Adson's or reversed Adson's or Wright's test, any of those. This is kind of helpful. Can't remember what it's called. Chicken dance test. Okay, so Ruse test. How long are you supposed to do that? You know, one place is said 4 to 5 minutes. Yeah, put your 95-year-old patient doing this 4 to 5 minutes and see if they gain anything. Oh, you have thoracic outlet syndrome, just like all my other 95-year-old people. Sclerotogenous pain can also refer pain to different locations. Usually it's not as distinct or specific as myofascial, but sclerotogenous pain, pain coming from the bones of the joints, can also refer to distal locations. Okay, here's misconception number 1. The most common cause for cervical radiculopathy is disc herniation. I can put that one to bed. Any questions on that one? Most common. Okay, most common thing is osteosporanal. Okay, there's other things that can happen, the posterior longitudinal ligament and osteophyte formation on the joint side or the vertebral side. Okay, number 2, most common cause, it's disc herniation. Okay, here's where the C6 and C7 nerve roots emerge. Okay, here's where upper cervical nerve roots emerge relative to the IVF. Here's where they emerge in the lower cervical, okay, C8. Okay, so even if the C7 disc herniates, it's less likely to press on the nerve at C8 just because it rides in the lower part of the IVF or the disc herniation. So it's interesting. Patients love posters in your office. I had the guy the other day. It's like, how is it that there's 7 cervical nerves? One was above cervical number 1. Oh, so patients sometimes they're just interested in stuff. So then we had to tell them, well, it's less likely to be compressed by the disc because the cervical 8 nerve emerges below where the disc is, the hole where the nerve comes up. So C6 and C7 are your hotbed locations of disc herniation symptom problems. So typical thing, C6 here, as one of my patients loves to do, C7. So if you do anything that's uncomfortable to him or anything, it's just so it's a big joke. It has to do with everything there. C7 to you. So patients are always interesting. All right, misconception number 2, they can trace a precise dermatome of loss. It's convenient to look at a dermatome and think that that's where a person has the pain. So if a person comes in with discomfort or pain here or in the C7 dermatome, I'm less concerned that they have disc herniation than if they come in like this. They have this constant pain going down between their shoulder blades. They're just like this, they're trying to do anything to just get to that constant deep pain. So it doesn't necessarily follow the same dermatome, and the ipsilateral border of the scapula, C6 and C7 nerve roots both do it. C6 would make more sense from the innervation standpoint, but they both can do it. The person's just like, they just love to get some kind of stimulation in there, something to kind of overload the system in that area so they don't process just the pain sensation. So here we come. Okay, pronation strength is actually more sensitive for weakness because of a C6 problem than your other C6 tests. 72% had one study had pronation weakness compared to wrist extension only in 36%. Okay, so if you really want to check for C6, pronation. It's not belt, it's not old school, so old school tends to be reprocessed. So that's, notice it's in red, so that's probably important. Okay, 40% probably people won't have sensory problems, so don't expect them to necessarily, oh, boom, 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 have all three of these things. Then, the other part of the slide, and I know you're only supposed to have one idea per slide, so I was going to do the slide 3 times. Okay, I changed it. Okay, now look at this part. Electrodiagnostic evidence of radiculopathy. Only only 14 to 34% complained that they had weakness. So they didn't. In other words, people have weakness and they don't know it. So if you ask them as a screening test if you have weakness, like their triceps or something, they might not know. I remember a patient one time he was having some radiculopathy. It happened to be C7, and so we were doing his muscle test. So we get to C7. I start going, okay, I'm gonna push in, don't let me, and it just collapsed. He was like shocked. He had no idea. So try to do a push-up. He had no idea. Even though he had pretty close motor weakness, but legitimate 4 creative muscle. So don't expect that they're only gonna have weakness if they can. Number 4, the area of numbness extends throughout the whole area of radiation. Don't know, it could be any part of the cervical, but when it comes to neuropathy, the distal nerves are affected more than the proximal part. So I always do sensory at the very end. You can't do the whole dermatome, you can, but it doesn't seem to have a lot of utility to do the whole dermatome of all of the dermatomes. And remember, this is the most iffy of the 3 anyways. Okay, so the end is probably the most sensitive part, but the nerve is the longest. The longest nerves are going to be the most prone to the problem. So in people that have true neuropathy, not compression neuropathy, people have neuropathy because they have diabetes or something else, where is the first place they have symptoms? The feet. Longer nerves have a tendency to be involved, or the shorter. Okay, number 5. One muscle is found weak for each nerve root. It's not that clean. Keep in mind, if you have severe neck pain and you contract to try to do something in your arms, you can do anything in your arms without contracting the muscles in your neck? Not very easily. So if that causes additional compression, they're gonna wimp out because it hurts. So it's not really being a wimp out. They're just having pain-induced weakness. So you have to subtract that part off. The other thing is to keep in mind that when you're doing muscle testing, the most common reason for a person's muscle to test weak is because they have pain. So if you do someone and their deltoid just collapses, like, oh, they have a C5 problem. That causes any discomfort? Oh yeah, that hurts. Maybe they have a concurrent rotator cuff issue or something, a supraspinatus problem. Yeah, so they're going to have weakness in that cuff. So again, does that bother you? And then next finer favorite question, where exactly? Point to it. What good is that? Because there's a big difference than if the person goes orthopolis. The more they can point to it, the more superficial structures probably come. So the person saying, yeah, I have chest pain, I think I'm having a heart attack. Well, where does it hurt? Right here. I don't think you're having a heart attack. It's pretty focal neurologic presentation. Right? Heart attack wouldn't be like that. People heart attack. Remember Levine's sign from PDX? Okay, you can't sell it right here. It's more like a costochondral problem. So pain inhibition is the most common reason for a muscle to be weak. Number 6, trauma is common in people who have radiculopathy, about 15% of the time. For those 15%, it's about 100% of the time. For the other 75%. Okay, conclusion then. They're common to have motor sensory reflex problems in radiculopathy patients, but it's not a given. It's not given that they'll have all. Okay, so let's break it down a little bit. Tests that are good for ruling out cervical radiculopathy. Okay, so if the person passes these two tests, it's not likely they have radiculopathy. They have 90-degree range of motion and it's uninhibited. Probably not radiculopathy. If you do the upper limb tension test, and this is for those people that it drives you crazy because, well, you do it kind of like that, Mary T kind of did it like that. What's really the right way? Okay, so here's the right way to do the upper limb tension test. Oh, you grab it with your hand. No, you push with your forearm. No, you get on this side. So you can see everybody's doing it a little bit differently. There's not even above the shoulder. And so that's what happens. You get somebody to describe something, and then different people try to perform it the way it's described. Sometimes there's some difference in the translation. So if you remember what the concept is and keep your eye on that, that's the important part. So if you're trying to determine radiculopathy, and you're doing an upper limb tension test, what are you trying to do? You're trying to stretch the nerve to see if it's irritated. So how can you most effectively stretch it? Well, if you push the shoulder down, that stretches on the brachial plexus. Okay. Then if you want to cause additional lengthening of any other part of the nerve that goes to the anterior surface, like the median nerve, then you want to extend them at the elbow and extend them at the wrist. So you want to do that all kind of together. Okay. It's an additive thing. So what makes a upper limb tension test positive? Well, if that reproduces their pain, and or if it gets worse when they flex away, because that's additional lengthening, right? And or it gets better when they bend ipsilaterally, which is kind of interesting because well, that's the same as a Sperling's A test, the ipsilaterally tip. So the other thing is if they have like 15 degrees less total range of motion into extension than the other limb when you do it on the other side, but nobody really knows about that or cares about that. I've never seen that be an issue. But the other thing is persons will get pain in different locations as you do that, and it gives you some other ideas that the person may have some tethering on the nerve in other locations as well, and then there's the whole concept of you can have more than one problem at one time. All right, that's all we have time for today, but I think we got the big concepts on the examination, and hopefully got rid of some of the misnomers on upper limb tension test. And our test is next month, test number 1, right? All right, so you have the PowerPoints, you have the assigned reading, and the stuff that we did in lab, so it should be all good. Through the end of this. Through the end of this, really glad.